All right, why don't we get going? Welcome to this session on essentially FDA approvals. And I think it'll be a very interesting session. I'm Eric Weiner from Yale, and my co-chair today is Laleh Amiri Kordestani, sitting to my right. We'll let everyone else introduce themselves in just a minute. I was thinking about this session and thinking about what it means and what you should hope to get out of it. And from my standpoint, it's more about understanding the process by which the FDA and FDA reviewers go through data and make decisions about what should and what shouldn't be approved and what patient populations should be included in the approval than it is about the specific drugs that we're going to be talking about. We will talk about two specific trials, and they will be used as examples. We'll also be talking about the ovarian toxicity of treatments, and that will be another topic. But this is meant to be very interactive. If you all don't ask a lot of questions, you're going to make me have to ask all the questions, and I don't really want to do that. So please engage with the speakers. And with that, I think we should just go ahead and go down and do the introductions. Do you want to say anything? Or?
Sure. Hi, everyone. It's really a great honor sitting next to Dr. Weiner here. We have actually prepared two short presentations for you from FDA, and also Dr. Wolff is going to give you a great presentation on ovarian toxicity monitoring on clinical trials, and essentially it goes very nicely with the recently published draft guidance on this topic. I'd like to thank also the organizers for giving us this opportunity to have this session every year. It's been a great experience for us. And please, Victoria. Thanks.
This is going to be interesting. Hi, my name is Victoria Goldberg, and I am so excited and thrilled to be here. And I can't thank the organizers enough for including us, the patient advocates, in this session. And as you probably know, I'm very humbled to be in the company of these amazing doctors. But I hope that the voice of the patients is important, and I'll be able to give you the information that we as patients would like to share with you. And so my name is Victoria Goldberg, as I said, and I'm a patient advocate. I've been living with metastatic disease for 10 years, and I'm very, very happy to be here.
Hi, everyone. My name is Antonio Wolff. I'm a medical oncologist at Johns Hopkins. I'm Chief Operating Officer of the Translational Breast Cancer Research Consortium, the TBCRC, and also co-chair of the NCI Breast Cancer Steering Committee. As Dr. Weiner mentioned, I think all of us want to learn a lot about how the FDA thinks and how the FDA does business. And I have the privilege at the end of this today, at the end of this session, to share with you some thoughts about issues of ovarian toxicity and what we should do going forward. And if there's a lot of industry folks here, do pay attention, because we really want you guys to step up to the plate.
Good afternoon, everyone. My name is Jennifer Gao. I'm one of the breast medical oncologists at the U.S. Food and Drug Administration, and also one of the associate directors at the FDA's Oncology Center of Excellence. I really want to thank you all and welcome you to this session.
Good morning, or good afternoon. I'm Tiffany Ricks. I'm a supervisory pharmacologist toxicologist at FDA. I lead a review team of non-clinical reviewers and in the Office of Oncologic Diseases.
Good afternoon. My name is Suparna Wedam. I'm a medical oncologist in the Division of Oncology 1 at the US FDA, and I'm on the breast and gynecologic team.
Good afternoon, everyone. My name is Mallory Fierro. I'm a supervisor in the Office of Biostatistics at the FDA, and my teams support the breast cancer teams. Thank you.
Oh.
So thank you, everyone. Now we would like to start with the first presentation.
Thank you. I will be discussing today the FDA approval of Ribociclib in combination with an aromatase inhibitor for the adjuvant treatment of adults with hormone receptor positive, human epidermal growth factor receptor 2 negative, stage 2 and 3 early breast cancer at high risk of recurrence. I have no disclosures. So in this presentation, we'll cover the background of Ribociclib and the approvals, discuss the NATALEE trial design, discuss the clinical efficacy and safety results from that trial, and conclude with some regulatory considerations. As many of you know, Ribociclib is an inhibitor of cyclin-dependent kinase 4 and 6, and CTKs function in cell signaling pathways that lead to cell cycle progression and cellular proliferation. In March of 2017, FDA approved Ribociclib for patients with hormone receptor positive, HER2 negative, metastatic or advanced breast cancer in combination with letrozole. This was based on the results of the MONALEESA-2 trial. Then in July of 2018, the indication for Ribociclib was expanded to include in combination with fulvestrant and for aromatase inhibitors overall, and these were based on the results of the MONALEESA-3 and 7 trials, again conducted in patients with advanced or metastatic disease. And today, we will focus the discussions on the adjuvant trial, the NATALEE trial, which was conducted in the adjuvant setting for the addition of Ribociclib to a non-steroidal and aromatase inhibitor. Shown here is a schema of the NATALEE trial design. We'll start from the left and move over to the right. Adults with hormone receptor positive, HER2 negative early breast cancer at high risk of recurrence were eligible for this trial after they had undergone surgery. The NATALEE trial defined high risk as patients who had anatomic stage group 2B to 3 disease, or patients with anatomic stage group 2A that was either node positive or negative with the criteria listed here on the left-hand side. Patients were randomized 1-to-1 in this open-label trial to receive either Ribociclib at 400 milligrams, 3 weeks on, 1 week off, combined with a non-steroidal aromatase inhibitor, anastrozole or letrozole, and goserelin as indicated. Ribociclib, again, was given at 400 milligrams, which is a lower dose than the approved metastatic dosage, which is 600 milligrams. Ribociclib was given for up to 3 years, and the non-steroidal aromatase inhibitor was given for up to 5 years. In the other arm, it was for patients randomized to a non-steroidal aromatase inhibitor, again, anastrozole or letrozole, as well as goserelin as indicated. A total of just over 5,000 patients were randomized. Randomization stratification factors included anatomic stage, prior treatment, menopausal status, as well as region of the world. The primary endpoint was local invasive disease-free survival per STEEP 1.0 in the intent to treat patient population. Overall survival was a secondary endpoint, descriptive, with no alpha allocated. Here we have an overview of the patient demographics that are enrolled into the NATALEE trial on the respective arms. For most part, the baseline demographics were well balanced when comparing the 2 different treatment arms. There were a total of 19 male patients who enrolled, as well as, of course, pre as well as postmenopausal female patients. There were slightly more patients that had stage 3 compared to stage 2 disease. The majority had node-positive disease as well as some sort of prior treatment for their breast cancer. Of note, the NATALEE trial did enroll few racial and ethnic minority patients, and this was a post-marketing commitment which we will discuss further later in this presentation, but I wanted to highlight it here. Next, we will discuss the results of the clinical efficacy and safety findings. The NATALEE trial was designed with 3 interim analyses. At interim analysis 3, or IA3, the invasive disease-free survival primary endpoint was statistically significant. However, at that time, only 20% of patients had completed their 3 years of adjuvant ribociclib, and there was, as a result, a high level of censoring. Due to these findings, FDA requested that the NATALEE trial continue and that the final IDFS results be submitted to the FDA for review. And at that final IDFS, 43% of patients had completed the 3 years of adjuvant ribociclib. And the final IDFS results are consistent with those of the interim analysis 3. Shown here in the table is taken from section 14 of the ribociclib prescribing information labeling, which shows the number of events, the hazard ratios, and the IDFS at 36 months. Correspondingly, the Kaplan-Meier curves are also shown, and again, these are in section 14 of the ribociclib prescribing information. As mentioned earlier, overall survival was a secondary endpoint with no alpha allocation and therefore considered exploratory and descriptive. Overall survival was immature with approximately 3 to 4% maturity, but the hazard ratio point estimate was below 1 with the 95% confidence intervals crossing 1. Median overall survival was not estimable, and the total number of overall survival events are listed here. And at this time, approximately 50% of patients had completed the 3 years of adjuvant ribociclib in the figure where we see OS maturity at approximately 4%. Again, although overall survival is immature and descriptive and exploratory, it trended in the direction of favoring the addition of ribociclib based on the point estimates. Safety was carefully evaluated in this adjuvant trial setting, and we have a fairly large safety database of, again, approximately 5,000 patients. If we were to take an overall view of the safety and adverse events, the overall signals were consistent with what we knew from the trials conducted in the metastatic setting, and these were already included in the ribociclib prescribing information in sections 5 and 6. More patients who received the addition of ribociclib to a nonsteroidal aromatase inhibitor did have toxicities compared to those patients who received an AI alone. And again, at final IDFS, approximately 43% of patients had completed the 3 years of adjuvant ribociclib, and 69% had completed at least 2 years. The adverse events of special interest included the ones known from the warnings and precautions of the ribociclib prescribing information, including neutropenia, hepatobiliary toxicity, QT prolongation, and interstitial lung disease and pneumonitis, with the incidences listed in this table. There were a total of 16 patients who died due to adverse events on the ribociclib plus aromatase inhibitor arm compared to 5 in the aromatase inhibitor only. The causes of death included COVID-19, pneumonia, pulmonary embolism, brain edema, cardiopulmonary arrest, epilepsy, as well as road traffic accidents. More information is available on the FDA's review of ribociclib in this adjuvant setting, which is publicly available on drugs at FDA. Next, we will go to discuss some of the regulatory considerations. On September 17th of this year, FDA approved ribociclib in the adjuvant setting with the indication listed here included in section 1.1 of the ribociclib labeling. Section 14 has information on the details of the design of the NATALEE trial, including how patients were selected based on the eligibility criteria. Of note, Section 16 does have new storage information that requires that ribociclib tablets be stored refrigerated at pharmacies, and then once it is dispensed to patients, it may be safely stored at room temperature for up to 2 months. Again, this information is included in Section 16 of the ribociclib labeling. There were a total of 2 post-marketing commitments agreed upon at the time of the approval. The first one focuses on the issue of diversity, which we alluded to earlier. The post-marketing commitment ensures that the company will conduct an integrated analysis that has a sufficient number of patients of racial and ethnic minorities that reflects the diversity of patients in the United States, especially those who are Black or African American, and that this analysis be submitted to the FDA based on the timelines that are agreed upon, shown at the bottom of this screen. The second post-marketing commitment, although I'm having a little trouble getting the slides to advance, is on overall survival. And that is to complete the adjuvant trial of NATALEE and to submit all additional overall survival analyses to the FDA as previously stated in the protocol and statistical analysis plan, including at the time of trial completion. Again, the agreed upon timelines for which these will be submitted to FDA are shown at the bottom of the slide here. Finally, in conclusion, we know that there have been a lot of discussions within the breast cancer community oncology group of the 3 different CDK4/6 inhibitors. If I could have the text help me advance to the next slide. This table shows the 3 different CDK4/6 inhibitors that have FDA approvals. Let me pause here for a moment to see if tech support could help us advance to the next slide. While that is loading, I want to just start off by saying that there are many caveats when we're comparing trials, and especially when we're thinking about efficacy results. As we know, the 3 CDK4/6 inhibitors are ribociclib, abemaciclib, and palbociclib. All 3 have approvals in the advanced or metastatic setting, and ribociclib and abemaciclib have approvals based on the adjuvant treatment settings. This slide is not meant to be a direct comparison, especially of efficacy of the trials, but is really meant to highlight some of the nuances in how these different trials were designed. Listed here on the left are the main categories that we wanted to highlight, including differences and nuances in eligibility criteria, stratification factors, the duration of adjuvant therapy, the efficacy results, and the adverse reactions that are highlighted in Section 5 in warnings and precaution of each of these respective product labeling. Of note, ribociclib in the adjuvant setting was given for 3 years compared to 2 years in the adjuvant abemaciclib and palbociclib trials. And at the time that the trial was designed, this is the duration that the company chose and provided some information in the preclinical setting with thoughts about possibility of benefit if the duration were to be given for 3 years. At this time, I think we don't have a good sense of what the exact optimal duration of treatment is, but again, at the time of the design of the NATALEE trial, 3 years was proposed and felt to be reasonable based on the available information. In closing, we know that in the curative treatment setting, the event rates are slow to accrue and large trials are needed to detect a difference. There was a statistically significant difference in the results of the adjuvant NATALEE trial, and the Kaplan-Meier curves did separate. We expect that the benefit, when we analyzed it, to be meaningful, and in this add-on design to an effective treatment, the results, we believe, will provide an additional treatment option for patients with early breast cancer at high risk. Overall survival, although descriptive and immature, was pre-specified during the trial design and collected prospectively. And again, a post-marketing commitment has been agreed upon for that information to be provided to the FDA at a future time. And finally, OCE has an equity program that really aims to improve diversity of patients that are asked to participate in trials and included in trials, especially reflective of the diverse patient population in the United States. There is a diversity action plan as well as FDA guidances, and FDA encourages companies to speak with the review teams on their plans. And with that, I want to thank the FDA ribociclib review team members, San Antonio again for the kind invitation to present, all of the participants on the NATALEE trial, and of course all of you in the audience and the patients who are here today. Thank you.
So we're now going to open for questions. Online we have received 3 questions, but if you would like to ask any question, we have, I think, 3 or 4 microphones. Please proceed to the microphones and then state your name first and then ask the question. Yes, please, microphone 2.
Nasir Haboubi from Menarini Stemline. Is there any drug approved in adjuvant using less dose than approved in metastatic disease in breast?
I'm sorry.
You're referring to other drugs other than ribociclib.
Correct.
So, did you hear the question, Jennifer?
Was the question, I'm sorry, we're having a little audio issues. Was the question, are there other drugs approved that have a lower dosage in the adjuvant setting compared to the metastatic? Is that accurate? Dr. Amiri, do you recall of any? I don't recall of any on the breast team off the top of my head, but I'll see if my colleagues have any information. Or if, sir, whoever asked the question, if you know of any other ones. I might also point out that we do have another session on dosage optimization following this one in, I believe, ballroom 3 and 4.
Sure, of course.
Yeah. So I actually think this is a very important question because I think we find ourselves, any of you who have done drug development, we find ourselves a little bit stuck on the concept of the MTD, the maximum tolerated dose, and that's the dose that is recommended to go into phase 2 and ultimately in phase 3. And that's how drugs are approved at the end. And I think to a degree the FDA finds itself a little bit stuck. And I think it would be wonderful if we begin to popularize and push ourselves, push industry, push investigators to actually not look into MTD, but in the minimally effective dose, which I think is the problem is we're doing a lot of these studies after the fact. A drug gets approved, we're now stuck starting on that dose, and it takes 5 years plus before we develop these additional data. And I think all of you who take care of patients, all of you do have the experience of patients, many patients after a couple of cycles, especially those who are having a clinical response. It's very common that we dose reduce. And I am yet to see an example of a situation where I have a patient who's having a clinical benefit from a drug when I dose reduce, that the drug, quote unquote, appears to stop working. And I also have the anecdote of, in many cases, starting those patients at a lower dose for various reasons, frailty, you name it. And my anecdotal bias is that the drug does work. So I think we need to become a little more creative in thinking about this. And I'm actually very happy to see that ribociclib was tested at a lower dose in the adjuvant setting compared to the metastatic setting.
So when we go,
Sorry, I see Dr. Shah from FDA actually, who is actually going to be chairing the dose optimization session is here and is presenting a response. So, and then we go to microphone 4. Thank you.
Hi, everyone. Marat Shah, U.S. Food and Drug Administration. Dr. Wolff, I could not agree with your point more. So I really encourage everybody to walk next door at 2 p.m. and come to our session, the clinical workshop on dosage optimization. I agree we need to stop relying on the MTD for all drugs, and we need to look at these questions early in the pre-approval setting so we're not left with these questions about the dosage at the time of approval. Thank you for making that important point.
microphone 4.
I'm Laura Biganzoli, I'm a medical oncologist from Prato, Italy. I really appreciate listening to speak about equity, referring to ethnicity, minority, and so on. But what about the elderly patients? I've seen the median age of the enrolled population was below the age of 60. We can no longer speak putting 65 years as barrier for defining the elderly. So I really invite FDA to consider also, that is not the minority, but it's going to be 50% of our future cancer population. Thank you.
I want to really thank you for raising that point. That is absolutely important. And the OCE equity program, I should have said, not only will encompass racial and ethnic minorities, but certainly there is an OCE project called Project Silver that is dedicated to inclusion of older patients with cancer in clinical trials, because we definitely agree that they are also underrepresented.
And it is worth pointing out that older women with breast cancer have a higher breast cancer-specific mortality than younger women. So it really is a significant public health problem. Microphone 2.
Is that me?
It might as well be.
Matthew Ellis, Garden Health. I was wondering whether the FDA was actually looking at Antonio's point more formally, looking at patients who did not complete their 3 years, had a lot of dose reductions and delays, and see how that interacted with OS and PFS data at EAT analysis to get some more information on this important point.
I guess I'm microphone number 2, but I apologize, I didn't know what number I was. But following up on Antonio's, I think that with novel trial designs and the way we're starting to do early phase trials, which we should have done many years ago, in combination with several of the guidances that are coming out in the FDA, not only are we going to look at optimal doses, but I think that it's not going to be a generic optimal dose. I think the time is now, and we're starting to see this moving forward, and unfortunately, I'm under CDA, so I can't be specific, but you're going to see different doses advancing forward in phase 3, potentially predicated on the tumor type, based on the biology of the disease relative to the biology of the drug.
And I think that the reason why this is so important, that as much as there is a commitment to do post-marketing studies, we are all humans. And I think our attention gets attracted to the next shiny object. And so for the company, the drug is approved. And so, yes, they will do it. It is the right thing to do, but it costs and takes resources. And so I would rather us having a little bit more regulatory teeth in a way to be able to answer a lot of these questions up front. Yes, there is always going to be the need for post-marketing trials, but the more we can do in advance, I think the better we're going to serve the patients we have.
I want to ask Victoria to comment on this.
Thank you. I was going to do exactly that. I wanted to talk a little bit about this. I was going to say a couple of things that I think are extremely important. As a person who has been living with metastatic disease for a while and running support groups and a podcast, I can tell you for a fact that there are no patients on Verzenio who have been on Verzenio for a while who are on a full dose of 150. There is just, it's impossible. Very few people, the quality of life, diarrhea, dose reduction is a normal practice. So I was quite upset about the Monarchy trial where they tested people at the same dose as metastatic dose. And I want to applaud the designers of this trial, the Ribociclib trial, that actually had made a big difference. The dose was reduced for the adjuvant patients. And again, this is not an easy drug either. You know, Abema is a very, very tough drug. Ribociclib is not an easy drug at all. People see neutropenia, which is a problem. There is liver toxicity that's a big issue as well. And again, many, many patients who are on this drug in metastatic setting are dose reduced. So the whole dose reduction issue is paramount for the patients, not surprisingly. And there is a wonderful initiative, and I'm sure many of you know about it, the Patient-Centered Dosing Initiative, that's suggesting exactly that. Let's stop doing the maximum tolerable dose and look at, we're in the world of precision medicine. At this point, there could be other decisions made based on person specifically and the dose that would work for that particular person. And I'm thrilled to be here and hear that this is something that the medical community is in agreement with us.
Thank you. Just maybe add about the comment that was regarding the FDA's analysis on the dose and response and toxicity. The clinical pharmacology section of the review that is part of the review and is now public actually lists the detailed information about it. So if anyone is interested,
Yes, and I also wanted to
Thank you.
to add, because it sounded like there was the question was also on, when patients did not complete therapy. So when we evaluated these trial results, we do look at the entire patient population, whether or not they completed the treatment. So this is part of the reason why we did ask for further follow-up for IDFS, so that we could have ensure that the results were robust and that they were reliable. And it's in this case, from a statistical perspective, there were enough events, IDFS events, that we could conclude that ribociclib was statistically significant. But we do look at everything from efficacy and safety for all of those patients.
So I want to take this in a slightly different direction. When you issue an approval, is that approval based on the eligibility of the trial, or is there additional work that you do to try to make sure that you're approving it for a patient population that's going to maximally benefit? And I ask that recognizing that there's a rather wide difference between a woman with a 2.1 centimeter oncotype 26 node negative cancer and somebody who has a 7 centimeter 15 node positive cancer. And of course, toxicity doesn't get adjusted based on anatomic burden of disease or other risk factors. So how do you deal with that?
I can start and then ask Dr. Fierro to chime in. So overall, we definitely look at the trial population that was enrolled in the submitted information. Now, we do get a very large dossier when it comes to us for regulatory review, and that includes patient-level data of every single patient who enrolled on their trial, all of the scans, all of the safety and adverse events findings, and we conduct an independent analysis, both from the safety, efficacy, as well as a multidisciplinary look at the overall package that's submitted. As part of this, as Dr. Fierro alluded to, we do look at the overall population, but then also look at the various different subgroups. And for this particular trial, certainly the different anatomic group stages of patients who enrolled that included node negative, node positive, and as you mentioned, different variations of how high risk was defined. And when we take an action, that indication statement that's seen in section 1 is very, very carefully worded so that it can be accurate, reflecting of the patients who enrolled in the trial, but also reflect what we find in our independent analyses. And I'll ask Dr. Fierro to chime in more a little bit about how we look at these subgroups.
Yeah, so there are 2 points I wanted to make. One is that we want to make sure that the patient population is sufficiently homogeneous, that it's not too heterogeneous, so that when we make conclusions about the drug, that we know that it's due to the drug as opposed to any differences or too much heterogeneity in the patient population. Within the trial population, subgroups or evaluating subgroups is very important to ensure that there's consistency in efficacy and safety from that perspective. So in this case, we really wanted to make sure across different subgroups, such as age or disease stage, that there were consistent results within those subgroups, and we did find that to be true for Natalie.
Yes, Victoria.
I wanted to take an opportunity and to make a couple of comments about this. So number one, I have looked at the trial data, and it seems, and I may be wrong on that, but it looks like about a third of patients did not finish their 3-year adjuvant therapy and discontinued. And that's an issue. It's a very serious issue. So there are questions, of course, arise. Why did this happen? Is it because of toxicity and people couldn't tolerate the toxicity and we can do something about it? Is it financial toxicity, which is quite high? I saw some numbers that say $370,000 for each patient, which is an enormous amount of money for an average person. But also, there may be some other issue. Is it maybe because patients don't really understand what it means to have a recurrence? Maybe they don't quite educate, maybe the education component is very, very important. maybe the doctors have to explain to the patients why we're doing this. Why this 3 years as opposed to 2 years or 1 year? And what it means to have a recurrence, that it's not something that, okay, you have a recurrence and then you will treat it and you'll go on with your life. This is not, in fact, the case, right? When you have a metastatic recurrence, your life is changed. It's a completely different situation. So that is something that I think needs to be looked into, and maybe some measures have to be taken about educating early stage patients about disease and recurrences and actually what stage 4 is. You know, I've had many conversations with early stage patients, and they were estrogen receptor positive, and they were surprised to hear that the rate of recurrence increases after 5 years, and it doesn't just go away. And that's something that I think maybe not something you have to tell at the first visit, but at some point that needs to be relayed to a patient. And my second point is related to that as well. What I wanted to talk about something else. So here we have 2 trials for adjuvant therapy where clearly the population, the high-risk population is clearly identified, right? So we're talking about people with probably stage 3, stage 4, other factors that go into the decision of their high risk. It's a lot different than the way it was 20 years ago when I was diagnosed. Now there is a lot more information on how to identify a high-risk patient. And of course, the Laleh trial was wonderful about expanding and including some people with intermediate risk. But what about those who are considered low risk? And there's a great article that just came out in the NCI journal by Stephanie Graf and others, Dr. Kalinsky and others, that talks about the largest group who is diagnosed with early stage breast cancer. These are people who are diagnosed with stage 1. And what about this group? And we know that in the first 17 years of the century, the drop in deaths from breast cancer is humongous. It's 40%. But the only group in the same period of time, in the same time frame, the only group that has not improved is the earliest stage group. The deaths that are resulted from the early stage diagnosis, obviously they did not die from an early stage diagnosis, they recurred, is growing. And that's something that we really absolutely have to look into. I mean, I'll have to go back and use my own example. I was diagnosed 20 years ago, stage 1, triple positive. At that time, I was considered high risk, obviously, and I got the treatment that high-risk people with HER2 positive disease got. I was lucky enough to be able to get the adjuvant Herceptin for a year and almost 10 years of endocrine treatments, and I recurred. And I'm thinking about what would have happened to me now had I been diagnosed now. And you know, the picture is not really rosy for me again. Of course, being a HER2 positive person, I would have been excluded from every CDK4/6 trial, Laleh and Monarchy. But even the HER2 trials would have excluded me. Catherine would have excluded me because I was nodal negative. So where would have I been now? Probably treated exactly the same I was treated 20 years ago. Adjuvant chemo, Herceptin, and endocrine treatments, and probably would have recurred 10 years later. So I urge you to look into the largest group. You know, there was, I think at ESMO, Dr. Tarantino presented some real-life data where it showed that 75% of people are diagnosed with stage 1. And only 9.7% were eligible for Laleh trial. So I urge you to look into this large group that seems to be not doing as well as the other groups and come up with a better way to identify those of us who have potential risk of recurring. Thank you.
Thanks. Why don't we go to microphone 1?
Dan Morrison, Hartford. In terms of the FDA's response to this heterogeneous degree of risk, 2 questions. The first is there some sort of internal inconsistency in requiring that the node-negative patients have a high oncotype score, whereas the N1A patients, who we already have learned in the postmenopausal setting to be of low risk, were not sort of assessed by oncotype, and we're left with no guidance for how we should think about N1 patients with low oncotype results? That's the first question. And the second question, in dealing with that thorny question of the 2A group, which we think probably has a lower risk, does the FDA ever mandate or require subgroup analysis with or without statistical power so that physicians can make their mind on their own? I find to date that data for 2A disease event rates lacking from all the presentations. I can't find it. So those 2 questions.
Thank you for your question. I'll start and ask Dr. Fiora to chime in, and in fact, also ask Dr. Weiner and Dr. Wolff to chime in on their input. So when we look at this data, because we have the patient-level data, we did do analysis of the 2A node-positive, node-negative results, as well as all of the various different high-risk definitions. Ultimately, the indication was granted based on the patient population, based on how the trial was designed. But if you go to drugs at FDA, our FDA review, which is several hundred pages, and in one of the sections, I believe section 8 on results, you find the detailed analyses of FDA's interpretation when looking at the various different subgroups. And I'll turn to Dr. Fiora.
Yeah, so when you ask the question about formally powering, from a statistical perspective, it would be ideal if we could kind of formally power every important subgroup, but it's not always feasible. So the types of things that we consider are the biologic rationale of whether certain subgroups might perform better, the mechanism of action of the drug. So for example, biomarker subgroups, if there's a biomarker positive subgroup, in that case, we may ask or recommend formal powering for both biomarker positive and negative so that we can make a conclusion about it. We cannot mandate whether there is formal powering, unfortunately. That's ultimately up to the sponsors, but in some cases, it is very important to do so. And ultimately, we want to make sure that there's no detriment in these certain subgroups, even if the subgroups cannot be formally powered.
If I could ask Drs. Weiner and Wolff, and I realize we have 2 other sessions to get to, but based on what you've seen in the discussions, is ribociclib in the adjuvant setting for the various different nodes and anatomic groups something you're comfortable recommending? How do you make that decision?
So let me come back to Victoria's point. Clearly there are many deaths in women who have very early stage breast cancer. The problem is, as a population as a whole, their risk of recurrence is quite low. And the answer isn't to treat everyone with toxic therapy to avoid, a 1% chance of something happening. What we desperately need, particularly for these lower risk patients, lower risk, still falling into the high risk category, is we need better predictors. And we need studies that look at those predictors that are adequately powered and will really answer the questions that help us. And, maybe we'll get there with ctDNA, but if we don't do a study that asks the question whether ctDNA is useful or not, and whether it changes ultimate outcome, we're never going to be there. So, I think we have to think differently about drug development in that the only way drug development is going to be successful is if we're successful at identifying those patients who really need those drugs.
Not to her question.
Oh, am I comfortable?
No, yeah, for node-negative disease.
I think that most patients with node-negative T2 disease are at relatively low risk. I don't know whether the toxicity of 3 years of ribociclib is worth it for those patients. I think there are some patients for whom it may be. I think patients make very different decisions. My big worry, though, is that doctors, and particularly medical oncologists, have a hard time saying no to anything. And there is this natural tendency, because we're trying to do our best to, pull out all the stops. And so if there's an approval, it becomes, the decision is really, should we not give it to you rather than should we give it to you? And I would just encourage all of my colleagues to have really thoughtful conversations with patients and explain all of these complex details to them. And some will choose to move forward with your guidance as a doctor, and some won't.
So I'll expand on what Eric just said. I think one of the things that drives me crazy is the idea of the treatment just in case.
Oh.
So just in case, we can do high-dose chemotherapy just in case. But back to your point, I struggle as well, because I think there's a lot of patients with, yes, they are at risk, but I have trouble quantifying risk. And I think we all, especially those of us who do a lot of breast cancer or only breast cancer, we develop our internal algorithms. A long time ago, we used to have an adjuvant online with Peter Ravden. I think that doesn't exist anymore. Many of us, I use for educational purposes with my patients the Predict from the UK Predict from the University of Cambridge. And I think that helps me a lot, because it helps me understand what is the risk of dying of something else. Because the public enemy number one for most patients with stage 1 and 2 disease is not breast cancer, is heart disease. We need to keep that in mind. And so that allows me to talk with the patient and with myself when I'm talking to the patient about what is the real benefit from chemotherapy, from endocrine therapy. It would be wonderful if a upcoming version, if anybody from the University of Cambridge here, if the next version of Predict does include some of the information from the CDK4/6 inhibitors as well, to be part of that education. Very quick point. Make sure that none of us is recommending ctDNAs as a standard tool in the adjuvant setting. I think for patients with stage 1 disease, I agree. It doesn't help to say 98% of you are going to be okay if you happen to be one of those 2% patients. We need better markers. Can ctDNA, other markers be used to assess minimal residual disease? And if we find something, is that early enough to intervene? Those are wonderful questions. We'll get there, not yet.
And on study.
On study right now, yes.
Sorry. Just a follow-up, please.
We're kind of like, we will take your comment, but then we also have a couple of good questions, and we want to move on because we have 2 other talks. So please go ahead. It's quick.
Just very quickly, what are folks saying about N1A disease, low-risk oncotype, postmenopausal, and risk as viewed in this trial?
I think silence speaks volume. I think we're all trying to digest the data. When you start talking about low risk, we pause.
Okay, thank you. So there is a question that maybe Dr. Gao, you can quickly answer. Is ribociclib contraindicated with tamoxifen?
Ribociclib causes QT prolongation, which we know tamoxifen causes as well. It is not indicated in combination with tamoxifen, and although the ribociclib labeling does not have specifically a contraindication, it is a warning and precaution, and it says clear that ribociclib is not indicated with tamoxifen.
There is a question that Dr. Ricks can comment regarding the storage condition change that happened in the labeling. Can you please expand on this, the reasons for it?
Yes, so one of the review issues that we had during review of this application was the presence of a nitrosamine impurity in the ribociclib. For the advanced cancer indication, the limits were acceptable. However, given the new indication in the adjuvant setting, the limits, or the nitrosamine needed to be controlled. We worked closely with the applicant in order to make sure that the levels of the nitrosamine impurity were within the acceptable intake limits. And so at approval, the ribociclib that's commercially available is within the acceptable intake limits. And so in order to do that, the storage conditions were changed.
Thank you. There is a comment about whether BRCA mutation or PI3 kinase mutations were actually assessed in this trial.
No, I believe they were not assessed in this trial.
Okay, thank you. So now I think we can, I see there are 3 other questions, but.
Quick? Really quick?
Okay, go ahead. You can start, yes.
Dr. Mohammed Shabali from Saudi Arabia. My question about, as we know that still there is a significant number of patients in NATALY trial who did not complete 3 years of adjuvant ribociclib. So do you think that in future we still need a non-inferiority trial addressing 3 years versus 2 years of adjuvant ribociclib? Thank you.
That's an excellent question, and essentially the next session that talks about the optimization of the duration addresses this, and that's always recommended to do that. Next question.
Judy Ann Chapman, Canadian Cancer Trials Group. Very quick support of what Antonio said, and also of the survivor. We had a number of endocrine trials, and we showed that all the endocrine trials, competing risks was the #1 factor, and it went by age. So it was about 50% of people, sort of 50-ish, who would die of something else, up to about 75% dying of something else, usually heart disease. So if that, just to round out all your conversations.
Thank you for your comments.
One more.
Last question.
Matthew Ellis, microphone 1. So I just want to pick up on Eric's point. This drug needs a biomarker desperately, a predictive biomarker. If the international community are going to do more trials on CDK4/6 adjuvant therapy, looking at duration or dose modification, please make the long list of potential predictive biomarkers part of the statistical design. There are a number of solid candidates that are not being investigated right now due to lack of access to samples.
Excellent point. Okay. So should we move on?
Yes.
All right.
We're now moving on to the second talk given by Dr. Wedam from FDA. It is regarding the Inavolisib's approval.
All right, great. Good afternoon, everyone. We've had some great discussion, but we have 2 more presentations here. So I am pleased to present the FDA approval of Inavolisib in combination with palbociclib and fulvestrant in endocrine-resistant disease on behalf of the review team. So, let's see. I have no disclosures, and listed here are the topics that I will be covering today. As a little bit of background, Inavolisib is an inhibitor of PI3 kinase, predominantly targeting the alpha subunit. It also induces the degradation of the mutated PI3 kinase alpha subunit 110 alpha. The approved indication for the triplet combination in the United States is shown here on this slide. Inavolisib is approved at a dose of 9 milligrams orally daily, and this is in combination with standard dosage of palbociclib and fulvestrant. Pre- and perimenopausal women, along with men, should also receive an LH-RH agonist with the combination treatment. PIK3CA mutations occur in approximately 35 to 40% of hormone receptor-positive breast cancers, and the presence of these mutations are considered a poor prognostic factor. At the time that Inavolisib was approved, available therapies for this patient population included endocrine therapy with a CDK4/6 inhibitor in the first line. This combination could also be given in the second line if not given up front. Additional second-line and later treatment options include other targeted agents, antibody-drug conjugates, and chemotherapy. Endocrine-resistant breast cancer is also part of the indication that was granted to Inavolisib and is also considered a poor prognostic factor. There is no uniform definition for endocrine resistance, but this generally refers to disease that progresses while on endocrine therapy or soon after completing endocrine therapy. INAVO120 is the pivotal trial that was used for the review of this application. Patients that were enrolled on study were required to have hormone receptor positive, HER2 negative advanced or metastatic breast cancer with a PIK3CA mutation. They were also required to have progression of disease while on endocrine therapy or within 12 months of completing adjuvant endocrine therapy. In addition, hemoglobin A1C had to be less than 6%, and the fasting blood glucose needed to be less than 126 milligrams per deciliter. Both of these cutoffs are somewhat more conservative than what is seen in other clinical trials evaluating drugs in this class. Patients were randomized 1-to-1 to either Inavolisib or placebo in combination with palbociclib and fulvestrant. Now, we do acknowledge that treatment preferences and recommendation guidelines have evolved. But at the time that this trial is, at the inception of this trial and conduct of the trial, palbociclib was considered an acceptable first-line treatment. Stratification factors included either the absence or presence of visceral disease and endocrine resistance, primary or secondary. And the definition that was used in this trial is shown on the slide, and also the region of the world. The primary endpoint was PFS by investigator assessment, and a prospectively planned sensitivity analysis of PFS by blinded independent review was conducted on all patients. Key secondary endpoints included objective response rate and overall survival. No crossover was allowed on this trial. 2 patients on the Inavolisib combination arm and 21 patients on the placebo combination arm did go on to receive a PI3 kinase inhibitor as subsequent therapy. The majority of patients that were enrolled on INAVO120 were female, and there were also 6 male patients. Other key baseline characteristics are shown on this slide and were well balanced. As noted in the previous presentation, Black and Hispanic and Latino patients were underrepresented compared to what would be expected in this patient population. This was a multinational trial, and there were 30 patients enrolled from the United States, and 30 patients from North America and 16 patients from the United States. The majority of patients had received chemotherapy either in the neoadjuvant or adjuvant setting, and few patients had received a prior CDK4/6 inhibitor, as the conduct of this trial primarily occurred before those agents were approved in the adjuvant setting. Shown here are the PFS results. At the time of the data cutoff, the primary endpoint of PFS by investigator assessment was considered statistically significant and clinically meaningful. The hazard ratio was 0.43, and the observed PFS, median PFS, was 15 months in the Inavolisib combination arm and 7.3 months in the placebo arm. And results by the blinded independent review were supportive of these primary endpoint results. Shown on the left is the Kaplan-Meier curve with a clear separation of the curves throughout. Since the progression-free survival results were significant, the first interim analysis for overall survival was conducted at the data cutoff, and the results are shown here on this slide. The hazard ratio is 0.64 and was not statistically significant, as the interim analysis stopping boundary was not reached. Therefore, the overall survival results are considered immature, and the Kaplan-Meier curves are again shown on the left. Shown here are select adverse events. The first 3 in the table are based on lab abnormalities. Neutropenia occurred at high rates and was similar in both arms and was likely due to the palbociclib treatment. Hyperglycemia, stomatitis, diarrhea, and rash all occurred at higher rates on the Inavolisib treatment arm and are known adverse events with PI3 kinase inhibitors. COVID-19 infection was also increased on the Inavolisib treatment arm. This trial was conducted during the COVID-19 pandemic, and this may be due to longer duration of treatment on that Inavolisib arm and the potential for prolonged neutropenia. Detailed information regarding the adverse events from this trial are all included in Section 6 of the label. Now, regarding adverse events of special interest, except for hyperglycemia, there were no grade 4 or 5 events. 74 patients on the Inavolisib treatment arm did require treatment with an oral anti-hyperglycemic, and 11 patients were treated with insulin. Discontinuations due to any of these adverse events was low. Hyperglycemia, stomatitis, and diarrhea are included in the warnings and precautions section of the label due to the seriousness and incidence of these adverse events. Dose modification guidelines are also provided, including recommendations for standard of care supportive treatment when indicated. Now, the safety and tolerability of Inavolisib was further evaluated through patient-generated data. Patient-reported tolerability based on select PRO, CT-CAE items, and modified bother index were assessed every 2 weeks through cycle 3, day 15, and then day 1 of every 28-day cycle. The completion rates on both arms were generally high. Symptoms that worsened from baseline generally occurred on the Inavolisib treatment arm. And the FDA focused on these descriptive tolerability results only and did not analyze the efficacy PRO data, as they were considered purely exploratory and based on time to event endpoints. Now, the patient-reported data provided further insight into the safety and tolerability of this approved regimen and is included in Section 6 of the label to further inform both patients and providers. Shown here is just a snapshot of what is included in that table. Included here are diarrhea and mouth sores. If you look at the first 2 columns, this shows the presence of these symptoms at baseline before treatment start. The next 2 columns show the rates of these symptoms anytime on treatment, and the last 2 columns show worsening of these symptoms to a grade 3 or 4, which translate to quite a bit or very much. So you can see the increased toxicity in several of the symptoms due to Inavolisib treatment. And so the increased toxicity seen with this triplet combination really does present an opportunity for future dose optimization. So regulatory considerations in this application included the fact that Inavo 120 did meet its primary endpoint of PFS by investigator assessment, and these results were supported by PFS by blinded independent review. The interim OS results are immature and not statistically significant, and there does not appear to be a detriment at this time, and we will continue to follow these. Regarding safety, there was increased toxicity with the addition of Inavolisib, as would be expected with an add-on design. And the clinically observed adverse events were supported by the patient-reported outcome data. So the benefit-risk assessment the FDA team felt that given this data, that the benefit-risk assessment was favorable for the treatment with the triplet combination for the specific patient population evaluated in the Inavo 120 trial, and this is reflected in the indication statement. Now, this approval is based on a biomarker-specific patient population. In Inavo 120, the PIK3CA mutation testing was performed either using a central ctDNA test using the FoundationOne liquid assay, or by local tissue testing or local ctDNA testing that was appropriate with appropriately validated assays. At the time of the Inavolisib approval, there was contemporaneous approval of the liquid companion diagnostic, and a post-marketing commitment was issued for the tissue companion diagnostic. So we often issue post-marketing studies at the time of drug approval. We have post-marketing requirements, PMRs, which are clinical studies or trials that the sponsor is required to conduct. We also have post-marketing commitments, or PMCs, which are clinical studies or trials that the sponsor has agreed to conduct. And I would like to highlight a few that were issued with the Inavolisib approval. First is a PMR, or a requirement to evaluate a lower dose of Inavolisib. Although there was adequate data with the Inavolisib at 9 milligrams to go ahead and approve this dose, there is limited data at lower doses, allowing us to maybe look at a better or less toxicity profile while maintaining efficacy. And this is one of the aims of Project Optimus, which is an initiative in the Oncology Center of Excellence at the FDA. And again, another plug for the workshop that's coming up at 2 o'clock in Ballroom 3 and 4. A post-marketing commitment, or PMC, was issued for the final OS results, as I did mention that the results at this point are immature. And another PMC was issued to evaluate Inavolisib in a more diverse population. As Dr. Gao discussed earlier, this is another big aim and initiative within the OCE with Project Equity. So in October of this year, Inavolisib was approved. It was the first FDA-approved treatment to be used in a triplet combination in breast cancer, specifically for the first-line treatment of patients with PIK3CA mutated, locally advanced or metastatic hormone receptor positive, HER2-negative breast cancer considered to be endocrine resistant. And this was granted regular approval. This approval was done under Project Orbis, which is a program that provides a framework for concurrent submissions and review of oncologic applications to other international partners. At this time, Inavolisib is only approved in the US. As I previously mentioned, hyperglycemia, diarrhea, and stomatitis are included in the warnings and precautions section of the label, and the patient-reported outcome data is included in Section 6 of the label. And I'd like to conclude with that and thank all of the patients that enrolled on clinical trials leading to this approval, to the entire Inavolisib review team, and to others that helped with this presentation, and to San Antonio to allow us to come and present. So thank you very much.
Thanks so much for a very clear presentation. We already have some questions. Microphone, I think that starts one there, so you're two. Deborah.
Deborah Pat, Texas Oncology. Thanks so much for your presentation. I think many of us in clinical practice are trying to put this in the perspective of what we do in the environment where we practice today, where we have other therapeutic options, though recognizing that it's a really important mutation to target in terms of people's first-line choices. And I have heard of people taking all sorts of permutations from the data that's out there to try to make assessments in clinical practice. I just don't know if you can, or if anyone at the table can speak to the experience of how you're using this in practice today.
Well, thank you very much for that comment. I will start, and then, of course, I will hand it off to Dr. Wolff and Dr. Weiner to comment. So we acknowledge many of the limitations that we had, and as Dr. Gao mentioned earlier, we do craft the indication statement based on the data that we have, the eligibility criteria in the trial, the pivotal trial, and any other supportive data that we might have. Now, understanding that, again, we have many limitations here. Palbociclib is not routinely used in the first line, and so could we use this with other CDK4/6 inhibitors? Could we use it with other endocrine partners? Do we have to use all three up front? And I'm hoping that we will get that information, and this will probably evolve how Inavolisib is used, in the future as we get more information. Of course, right now, I would not advocate for treatment outside of the combination that was approved. And again, given the toxicity and some of these limitations, we feel that the benefit-risk profile was warranted specifically, again, for that patient population that was treated in Inavo 120. So, a very kind of well-identified, high, poor prognostic group that is considered endocrine resistant with the PIK3CA mutations and really kind of should be used within those confines right now. But thank you for the question. I think there's more to come. I don't know if you, Dr. Wolff or Dr. Weiner, if you have any.
You can go ahead.
I think, so I was actually, during the presentation, I was catching up on my tablet on a very nice editorial that Bill Gradishaw wrote, accompanied this paper in the New England Journal in October. And I think he asked an important question. So let me say this, the data are real. So this is a real result, there's no question about it. But there is the inevitable question about, what is the ultimate benefit of piling up all the drugs in the first-line setting? I don't think that there was any crossover in this study, so there was no crossover. We have a number of examples in the past where if you don't cross over, it becomes a clinical trial of a new drug now versus new drug never. And in those studies, those scenarios where you have a drug that is clearly effective, and this one is, you ultimately are bound to, at the end of the day, show a survival benefit. When you have crossover that extends beyond 25% or so of patients on the control arm, that survival benefit tends to disappear. So that is an important question. What happens if you, for the future, if you actually don't combine 3 drugs, if you sequence drugs, and at the end of the day, all patients have access to all drugs at some point? So I don't know the answer to that, but I think we need to keep that in mind. When you combine drugs, you have more toxicity, financial toxicity, costs. So I'm this is real. It's incredibly impressive. I'm still clinical experience. Most of us have almost no clinical experience because it is a new approval. So I think we're beginning to learn.
So about 15 years ago, I actually was asked to go to the FDA to give a talk on whether PFS alone should be an endpoint. And I actually at the time argued it should be, but only in certain circumstances. One of those is when you really believed, even in the absence of quality of life data, that your extension in PFS was likely to lead to an improvement in quality of life. And the other is when the PFS extension, unlike some of our trials where it's 2 months or 3 months, it's much more substantial. So I think it's okay to use PFS here, although I think it's worth all of us remembering that we haven't proven that people are living longer as a result of this. And I'll bet Antonio hasn't used this combination yet. Am I correct?
I have not used the combination
Nor
yet.
have I. However, where I would use it would be in the patient who recurs on adjuvant endocrine therapy or very shortly afterwards, as was the case in the study, in somebody with a PIK3CA mutation, which we know is in the metastatic setting a poor prognostic finding, and in somebody with a relatively high volume of disease and probably visceral metastases, because a lot of the patients in this, a minority of the patients in the study, for example, had bone-only metastases. And in that patient population, I talk about it as an option, recognizing that it has more toxicity than just giving a CDK4/6 inhibitor by itself. So I think that the study and the approval in many ways creates more questions or creates some questions that we don't have answers for. And I think we're going to have to tease that out. Will one of the other CDK4/6 inhibitors be effective after giving palbociclib here? The truth is probably yes, and that's a good thing. But we need to, again, understand all of these issues.
Yeah, so only about, I was just looking at the paper, so only about 3.5% of the patients had bone-only disease.
Yeah.
That is not the population that you should be thinking about using this. 80% of the patients had visceral disease. That is a population, as Eric said, to consider something like this.
Microphone 2.
Yes, this is Faris Tamimi, Ken Hussein Cancer Center. My question is, especially when we are talking about
medications expected to have higher toxicity in the experimental arm versus lower toxicity in the control arm, the time to event could be misleading in terms of using progression-free survival as endpoint. For instance, imbalance censoring and informative censoring is an issue. For instance, here, could you clarify patients who were withdrawn from the clinical trial, have they ever progressed? I mean, in some clinical trials, patients who withdrawn will never progress, and the only event that they can reach is death.
Yeah, I wanted to make a comment on that. You know, for all of our trials, we do take informative censoring very seriously. So informative censoring is a concern because it may come to a conclusion of a false positive. This is why we want to look into it. In general, if there is some asymmetric dropout such that more patients on the control arm or the treatment arm are dropping out compared to the other arm, we do look at that very closely. We do a panel of sensitivity analyses that are conservative, or what we call tipping point analysis, to ensure that the results are robust. And so in this case, our statistical reviewers do their own independent sensitivity analyses to ensure that the results are robust, and in this case, they were robust.
Thank you.
And just the other comment I will make is that discontinuation rates on this trial were actually quite low, but what Dr. Fierro is saying, kind of is across the board for any of the applications that we're considering.
Microphone 2.
Thanks, sir. Nasiha Boubi Minari Stemline. Many PI3 kinase inhibitors reviewed by the FDA, and almost all of them, they give hyperglycemia. Scientists at the discovery, they believe that this hits the target when you develop hyperglycemia. Is there any hint about the outcome of those patients who develop hyperglycemia? Are they behave the same or better?
Yeah, so in this trial, again, I had presented the rates for the hyperglycemia and the number of patients, 74 patients that did require oral antihyperglycemics. Most of those patients were treated with metformin and 11 patients with insulin. These were kind of smaller numbers, the insulin and the oral hyperglycemics, but there did not appear to be any difference in the patients that developed hyperglycemia compared to their efficacy outcomes.
That is actually very helpful because I think we don't need to hit the patient hard. We want to hit the disease hard. In a number of other examples, taxanes and neuropathy and others, you don't get greater benefit by hitting hard. So dose reduction, again, in many patients may be appropriate.
Well, that's a perfect segue to Victoria. So the question I have for you is a treatment that has somewhat more toxicity, that extends the time that someone is stable or responding to a present treatment, but doesn't necessarily make you live longer. How do you think about that trade-off?
Okay, so I'm not a doctor, and I don't play one on TV, but I have a very strong opinion about this particular triplet. Of course, I'm not new to triplet. I started my metastatic, my first line of treatment was a triplet. But this particular group is very unique and very special. For those of us who do a lot of patient advocacy, we come across usually young women, and I think about 50% in this trial had premenopausal women. We come across these women who fail, well, I shouldn't say fail. The drug fails them within the first year, even sooner than that. And we see the story over and over and over again. They don't live very long. And the landscape analysis, by the way, of this trial had a very interesting number, in my opinion. After 6 months, it showed that the control arm, 90% were still alive, but 97% were alive on the treatment arm. And in my opinion, that's an indication of how the drug is going to be doing. Another thing, 50% of the patients had visceral disease. I had extensive liver mets at my first diagnosis, and having been hit hard, I think helped me a lot. So I have a very strong opinion about it. I feel that this drug, and it has shown, this combination has shown clear efficacy, clear efficacy. I think this is a very, very important drug, and I'm so pleased that I see it now, and I think it's gonna help this special group of people. And of course, there will be other things that will be taken into consideration. Of course, the adjuvant CDK4/6 inhibitors that had not been used very commonly for this trial. I think there were only a few people who had had CDK4 before they started on this trial. That would make a difference. I have a question about what do you do when there is an adjuvant CDK4, Abema, and Kisqali, thank you. And then you recur, and your first line is Palbo, and we all know that that sequencing doesn't actually work. So I have questions about it. I also have questions about substituting palbociclib for the other two drugs. My feeling is that given the additional toxicity here, the other two combinations are not going to be very good for quality of life for patients. But overall, I'm very, very excited about this drug. I'm also, everybody knows that alpelisib is not something that people like, and so this is another option, and it looks like a better toxicity option. And I'm also very interested to see the results of a triple trial for capivasertib and these other two ones. But to answer your question quickly, I think, yes, absolutely. I think this particular group needs this drug, needs this combination, and will tolerate additional toxicity.
Thanks, Victoria. We take one more question, and then we want to, since we have another presentation and we're short, please, a quick question.
Elżbieta Sankus, Medical University of Gdańsk, Poland. And what I'm worried about with this registration is palbociclib. And this has already been alluded to, but I have one more philosophical comment, which is, aren't we trading something we know, the better CDK4/6 inhibitors for, as it was very nicely said by Dr. Wolff, the shiny object? And my second question to FDA people is, what would need to happen that actually the approval is changed to CDK4/6 inhibitors instead of palbociclib?
So I'll just start with that first, and then maybe let Dr. Wolff and Dr. Weiner speak. So when we approve a drug and we put out the drug label, this is really a living document. And so it is always changing, always being modified. And if there's new data that comes in that supports the combination with another CDK, if there's another indication, if there's new safety data, we're happy to put that in. So we are always editing and modifying the labels. And so what it would take is some data with other CDK4/6 inhibitors. And I know that those trials are being done. So, again, I'm also curious to see what they'll show. And if that is supportive, then we would include that in the label. Thank you.
I have no problem with this, the approval with palbociclib. We know palbociclib works in metastatic disease. We use it all the time. We don't have survival benefit. That's a separate conversation. But the studies with the other CDK4/6 inhibitors are happening. So we'll have that information at some point. Zero trouble with the approval as is.
Thank you. And now we're actually moving on to our third presentation, Dr. Wolff, to discuss the monitoring of ovarian toxicity during clinical trials. Thank you.
We only have about 20 minutes left for this session, so I'll try to present my slides a little bit faster, and so that we have enough time for discussions and a conversation. So I was asked to talk about the monitoring of ovarian toxicity during clinical trials, and I think that this is an incredibly important point. The message that I think we heard today is that the majority of the patients with a new diagnosis of breast cancer, early stage disease, will survive breast cancer. They will have, in some cases, to live with the consequences of our good intentions. So we need to be careful about the issue of ovarian toxicity, which for many patients is a hidden toxicity. It is not as apparent as alopecia, diarrhea, and mucositis and others, but it's something that will affect their lives later on, including the issue of having children. I was privileged to join the FDA and other colleagues at ASCO at a workshop that took place in October. And I want to acknowledge all the speakers who presented. I'm showing some of their presentations and data today. Drs. Lauren and Wedam were the co-chairs, and that's the reason why I'm showing this in advance, because we should acknowledge the work that they have done. I encourage you to go online and look at these presentations. They are available for streaming. My cursor is, the mouse is not, oh, the wheel, okay, the wheel, all right. It does work. So I think we need to keep in mind that the chemotherapy effects on the ovaries impacts everything, not only in terms of quality of life toxicities, but also health after breast cancer, as I alluded, especially in terms of accelerated bone loss, cardiovascular disease, earlier premature menopause. And I think we also need to keep in mind that the fact that a woman continues to menstruate has nothing to do with the ability to bear children, bear a pregnancy. It's not synonymous with fertility. These are data from the IBCSG and Partridge-Gelber a number of years ago. When you look at the ability whether women are menstruating in the second year after diagnosis, after having received chemotherapy, and we see for very young premenopausal, but also older premenopausal women, it does look like you lose about 3 years of menstrual life when you receive adjuvant chemotherapy. That's what it seems to be happening here. And also we do know that these are older data from Jean Petrek, from the late Dr. Petrek, from about 20 years ago, showing that when you go from AC to AC followed by a taxane to CMF, that you have a higher chance of not continuing to menstruate. It does appear on the right side that the younger women may be more protected from these cytotoxic effects in the ovaries from chemotherapy. But this is a little bit misleading, because when you start measuring in young adults, I apologize for the typo, for adolescents and young adults with breast cancer, that when you intensify the chemotherapy and you measure levels of AMH are going to be lower with more intensive chemotherapy, even in very young patients. So let's be careful with that. We also need to keep in mind that there's a natural decline in gonadal function with age, not only for women, but also men. 1% of breast cancer patients are men, and this is something that goes beyond breast cancer. We tend to forget about men, especially at a meeting like San Antonio. And so here what we have, the reason to keep this in mind is because if you look in the bottom left, there's a natural trend, not natural, but there is a trend of delayed childbearing in the US, and so women are having children later, and women, when diagnosed with cancer, are now playing catch up. Incredibly stressful, no need to emphasize that. In terms of the drug effects on the mechanism of female fertility, I bolded and highlighted some of the drugs that we commonly use in breast cancer, and you can see the targeted pathway and the potential relevant function that is affected when it comes to female fertility. But the problem is that we do have a lot of good data, but we don't have all the information we need for those of us in the clinic talking to patients, educating patients. Quite often we see comments like fertility studies in animals have not been conducted, and then you see in the bottom on the left side, on the top left, you have tucatinib, in the bottom right you have atezolizumab, and essentially this drug may cause fertility problems in female, may affect their ability to have children. Talk to your healthcare provider. And now the patient will come in, talk to me, and I don't have enough information to guide them. That is not a comfortable place to be for the patient and for us in the clinic. We also need to keep in mind gonadal toxicity in males. A lot of men diagnosed with cancer already at that moment will have lower sperm count motility at presentation. But what we tend to forget to warn them is that if you look at evidence of DNA damage in sperm, that may persist for a year or two after exposure to chemotherapy, and that puts them at risk of unsatisfactory or problematic pregnancies in the future. So they need to think about contraception. There is some guidance from the FDA, but the data in men are much less developed than it is in women. This is actually one of my favorite slides. This slide I created about 20 years ago or so. This is IBCSD trial 8, which was a adjuvant therapy in premenopausal women, very young and older premenopausal women. No therapy versus goserelin versus CMF and goserelin. When you look at the chemotherapy arm, a lot of women after the cessation of chemotherapy, they don't recover menses. What is fascinating and so educational for me at that time is that if you do ovarian suppression and then you stop ovarian suppression, ovarian function will be exactly the same many years after therapy compared to the control arm. So ovarian suppression may work as a therapy, in some cases may work better than chemotherapy and has no deleterious effects on ovarian function. The reason I show this is because for those of us who like me, who train in the late 90s, so we feel, and who were trained by people like Eric, people like Aaron Goldhirsch, Rich Gelber, and others. And I see what is happening today. When I talk to my colleagues, the younger generation, I see a very strong bias towards chemotherapy as the preferred strategy for young women. And I think we have enough data to suggest that perhaps what these patients really do need is effective ovarian suppression, combined ovarian suppression. So if we are talking about avoiding toxicities in terms of preserving fertility, how about figuring out whether we can really avoid chemotherapy for a lot of patients? 20 years ago, we succeeded in doing the soft trial and the TEX trial. We failed miserably in the CREW to the per-case study, ovarian suppression plus minus chemotherapy. We could have answered this question, and now we have launched in the US, the BR009 study is not accruing as fast as we wish it could. I urge all of you to go back to your institutions and think about activating this trial. We failed in doing per-K. This is the last chance we have to ask this question: do young women really need chemotherapy or not? Because if we don't succeed with this study, we are condemning patients, young women, forever to receive chemotherapy. We'll never be able to answer this question satisfactorily. In terms of tools, there's a lot of things we can do in terms of collecting data, standardizing clinical data, laboratory data that we need to collect prospectively in clinical trials. FDA guidance to industry, so study of fertility and early embryonic development not warranted to support clinical trials in patients when we're developing drugs for patients with advanced cancer. But the reality is a lot of these drugs will move into the adjuvant setting. So the Q&A indicating that a program on reproductive and developmental toxicity are likely needed prior to marketing if you're going to be using this drug in the adjuvant setting. I think this is very weak. Likely needed is very mushy. I think we need to have a stronger stance on this. It should be mandatory. It should not be likely needed. So these are slides from Dr. Wedam at the presentation that she gave at the workshop ASCO FDA. We have some guidelines about counseling. There's confusion on the data to collect. CTCA criteria are clearly inadequate. We need to understand the likelihood of ovarian toxicity so that we can inform the patients we see. ASCO put together a task force, issue a research statement on what should be included in terms of measuring ovarian toxicity in clinical trials. It is important. We need to collect data. We need to collect clinical data, we need to collect laboratory data, we need to do this. And these are some of the recommendations. Measurement of ovarian toxicity in relevant clinical trials need to take place. The collection should occur at baseline at 12 and 24 months after anti-cancer agent cessation at a minimum, and later in line with the trial schedule. These patients are many of these patients are going to survive breast cancer. They need to survive our treatments as well. And we need to assess clinical measures and biomarker functions. Here are the time points. You can look at this more carefully later. Conclusion, the assessment of ovarian toxicity is important. We need to come up with a minimum common lower denominator of criteria of data that we are going to collect routinely and systematically. And I think this is so incredibly important. This is a statement from ASCO on making sure that all patients have access to fertility preservation during cancer care. And again, this data from Partridge, many of you may have participated in the positive trial. The study did show that a lot of patients who pause adjuvant endocrine therapy after a couple of years go on to successfully have a pregnancy. Indirect evidence between comparing the risk of developing breast cancer recurrence, indirectly positive versus the soft index data, suggesting that we are not seeing a greater risk of developing a recurrence. This guidance in draft format was just issued by the FDA a month ago on the assessment of ovarian toxicity in premenopausal adults during drug development. This is a guidance for industry. And if we can highlight the recommendations, so clinical parameters, laboratory markers, bullet number 2 should be the default, that this is going to be done routinely. I do not like bullet number 3. If the sponsor justifies why it is not able to assess ovarian toxicity during pre-market trials, the sponsor should discuss a plan with the FDA to do it after. And you heard my thoughts earlier today about the issue of post-marketing studies. Chances they may not happen. We're not going to have those data for a long time. So this has to become a priority. This is in draft format. I do hope that the final version of this recommendation has a different last bullet, and I submitted a comment. And you actually can go online and submit comments as well. Industry, I hope you're listening. And with that, I will stop here. Thank you.
Questions? So I'm going to ask you a very practical question. You start a patient on ovarian suppression, on an LHRH agonist, and you want to make sure that you are actually adequately suppressing them. Do you and when do you check blood tests to determine that, in fact, you have put them into menopause?
So the question is whether should we measure FSH estradiol routinely on patients on ovarian suppression. I used not to, but this has a lot to do with the fact that we were using gosiralan. Gosiralan is an agonist. It's not a complete antagonist. And actually, the only complete antagonist available in the US is triptorelin, which I believe only has an approval indication in prostate cancer, does not have an approval in breast cancer. We have transitioned more and more to, I call it step 1, 2, and 3 when I discuss with patients. Tamoxifen, step 1, ovarian suppression and tamoxifen is step 2, ovarian suppression with an AI is step 3. I always worry when I add the aromatase inhibitor and move away from tamoxifen to an AI in the setting of ovarian suppression. So I am checking in those patients, I am checking estradiol FSH before I transition from OFS tamoxifen to OFS AI. And I watch a couple of months later.
Thank you.
I wanted to briefly comment on the ICH S9 guidance comment. So it was mentioned that, fertility studies likely may be needed. I wanted to kind of talk about how FDA interprets that. It's an international guidance, but how we interpret it it's really a totality of the evidence approach. And so if we have enough information without having to do dedicated fertility studies to say that there is a risk there, then it may not be needed. If it's unclear based on mechanism of action, based on the animal data that we have, then a dedicated fertility study would be expected.
Microphone number 3, please.
Hi, Maxime Ruits, UZ Leuven, Belgium. I was wondering if you have a proposal also to follow up on miscarriages and fertility after breast cancer treatment, because I don't know if FSH will be enough to be able to have a pregnancy afterwards.
I can comment on that first. So thank you for that question. So I think, really kind of the genesis of this whole project of having the white paper with ASCO, the workshop in October, and the recent draft guidance was just understanding that much of this information is not even collected. So to just get started, we're cognizant of the burden that this could add, maybe with more questionnaires, the information we need to collect, some blood tests, but it's so important. And so yes, the clinical factors that we are saying, and they're written out in the white paper, they're in the guidance, not only including, is a patient having their menses, yes or no? We don't collect that. Have they resumed? Have they attempted pregnancies? And confounding things as far as, do they have a hysterectomy and oophorectomy, so they're not going to get pregnant? Did they need any kind of reproductive assistance prior? So to start collecting that information. I think the clinical information is less of an ask. Even what we're saying is that even when after a trial is done and you call for follow-up to see if a patient is alive or not, to ask these clinical questions, and we can start getting that. And you can be somewhat flexible with the blood draws, doing it at baseline, at the end of a study, and later on if there's any kind of blood test or anything that they're getting. These are tests that have been done for a very long time. Yes, they're not free, but they are cheaper compared to a lot of other tests or imaging or other things. So yes, attempted pregnancies and all of those things are things that are recommended that that be collected.
Yeah, I agree, it's very relevant, yes. Thank you.
A virtual question, Antonio, I'll pose this to you. Do you start an aromatase inhibitor when you start ovarian suppression, or do you wait?
So we all create our own imperfect, inadequate ways of taking care of patients. I mean, tamoxifen works. Ovarian function suppression plus tamoxifen for high-risk patients is going to be a little bit better. OFS and AI is going to be a little more better, or better more, whatever you want to say it. What doesn't work is the drug that you can't take. If you don't take a drug, it can't help you. So I don't like to throw the kitchen sink at patients, so I will say almost never begin OFS and AI right away. I usually start step 1. The patient gets to know what is tamoxifen, and then we move to step 2, and then we move to step 3. And if they can't handle, we can come back to 2 and 1. It's my own imperfect hack. It seems to work.
So your patient is already on ovarian suppression when you're starting them on an AI?
I usually tend to go OFS tamoxifen before I go OFS AI. It's just my own bias because I want to be kinder to them, perhaps.
I think to answer the question of for the patient who's starting up front on both treatments, I think most of us tend to start ovarian suppression and then wait a month before adding the aromatase inhibitor.
Yeah, it makes sense because I think I want the patient to know what is how do they feel on drug number 1 before I add drug number 2, because otherwise they have no idea what's causing what.
All right.
There's one question also virtually that is asking about the specific test that I actually asked that you review the guidance. It's very short, so you can actually get there. And also, I don't know if there are specific levels of FSH and E2 that you, for example, monitor patients. Any specific threshold for FSH or estradiol that you actually want patients to have?
So I don't think we have any evidence. Mitch Dowsett may not be in the room, but I don't think there are any evidence to show that greater levels of suppression are associated with improved clinical outcomes. I think my greatest concern, my specific concern is when you use LHRH agonists like Cosiralin and you add an aromatase inhibitor, because you could trigger an escape. You are not supposed to see that when you use a complete antagonist, LHRH antagonist like triptorelin. There's a question in one.
Yeah.
Last question.
Daniela Prescu, a medical oncologist, UK. I'd just like to ask the panel whether they would promulgate the ovarian preservation, ovarian fertility during the adjuvant chemotherapy by using LHRH analogs such as Zoladex. And what sort of regimen do you use in your daily clinical practice in this setting?
So I think this was the SWOG study by Halle Berry a number of years ago. It was done with Cosiralin, and which is the drug we more commonly use in the U.S. So I routinely discuss with premenopausal patients. Eric?
It works. And beyond that, in a patient with triple-negative disease who you don't see any advantage to, or I don't see any advantage to turning off their ovarian function, then it is also something you consider if someone doesn't want to have a child but wants to preserve ovarian function.
In the community, oncologists who also treat prostate cancer, I see a lot leuprolide being used in the community in the U.S. Because doctors get used to, we use one drug, so they use leuprolide for prostate and breast cancer. I only treat breast cancer, so I tend to use Cosiralin. As Eric said, it helps preserve it helps preserve menstrual function. I don't know if it translates into fertility, but it may translate into improved metabolic health as they survive breast cancer and move on with the rest of their lives.
Do you use it for the duration of adjuvant chemotherapy, 3-6 months?
Yes.
Yeah, depending on the regimen?
Yes.
Okay, thank you very much.
Started before, continue to the end.
Start before, continue to the end, yes.
Thank you so much. Now we have to end this session. This was wonderful having you all actually with us. And if you have any questions, feel free to email us after the meeting. Our emails are all online. Thanks, everyone. Bye.